and mimic, and this feedback mimic the point what the examiner wants, definitely you will pass it. So I hope all of you good luck for your coming exam, and I'm free to answer any question any people want to do. And I hope that in the coming weeks I will join you and I give you my experience. Thank you very much.
Thank you so much, Dr. Abdullah. So anybody from among the audience, anyone to ask any question from Dr. Abdullah, you can, you are most welcome. No one? Okay, so then I hand over to the Zubia and Dr. Sabine. So they will conduct a session with all of you. There are few candidates who are already wished their participation. So we have their names. So Zubia, you can continue now. Thank you so much.
Okay, thank you, Dr. Amreen. So I have Dr. Tabinda with me. So I'm starting my screen sharing. Okay, Dr. Tabinda, can you see my screen?
Yes, ma'am. Yes.
Okay, okay. So I will start your 2 minutes, and then I will also, this is the scenario, and I'm starting your 2 minutes time. First read the scenario, then I will ask the questions from you.
Okay.
If you're ready, we can start before that as well. Shall we start, Dr. Tabinda?
Yes, ma'am.
Okay. Now start the station. How will you start?
Hi, I'm Dr. Tabinda, one of the exam candidates, and I'm ready for the structured discussion.
Okay, okay, Dr. Tabinda. Your first question for this station is that define the postpartum hemorrhage.
Postpartum hemorrhage is the amount of blood loss after delivery of the patient, and the amount of blood loss, it can be it if it is more than 500 ml, then we will alert. And there are two types of postpartum hemorrhage, like minor and major. And if the blood loss is more than 500 ml, then it's minor, and if it is more than 500 ml, then it is major. If it is more than 1000 ml, there are so many causes of postpartum hemorrhage. It may be due to uterine atoning, due to any retained product of conception, due to any
Okay, okay. We will move to the next question now. So, what are the types of postpartum hemorrhage?
The types of the postpartum hemorrhage are minor and major.
Okay.
if the blood loss is less than 500 ml or more, then it is minor, and if it is more than 1000 ml, then it is major. And in the major, we divide it into two types. And if it is more than 1000 ml, but it is not associated with shock, and if it is more than 1000 ml and it is associated with shock.
Okay. So moving to the next. So what are the causes of postpartum hemorrhage?
The causes of the most important cause of the postpartum hemorrhage is uterine atony, and it may be due to retained product of conception. It may be due to any cervical or vaginal tear. It may be due to any coagulopathy. It may be due to any that's it.
Okay. So how will you manage if it's the minor PPH?
Okay. If it is minor PPH, I will alert the team, and I will pass only one cannula of 14 gauge, and I will send the blood group and full blood count, and I will rub up the uterine fundus, and I will show the cause of PPH.
Okay. Anything else that you want to add?
And I will empty the bladder, and I will give the oxytocin, and I will again reassess the patient.
Okay. So your next question is, after what will be your initial management in this patient on arrival in the room?
As this patient is bleeding profusely, and so I will assess the blood loss, and I will call for help, and I will make a team of senior midwife and obstetrician and anesthetic, and I will alert hematologist and blood transfusion laboratory and consultant obstetrician. I will resuscitate the patient. I will see the airway breathing and circulation, and I will give the oxygen 15 liter by mask, and I will pass 2 IV cannula of 14 gauge, and I will start giving fluids, which is 2 liter isotonic crystalloid, followed by 1.5 liter colloid, and I will rub up the uterine fundus, and I will empty the bladder, and I will give oxytocin 5 international units flow IV, and followed by ergometrin 0.5 milligram. And if it's still PPH doesn't settle, then I will give the oxytocin infusion. And if it's still patient is in PPH, then I will give the carboprostol 0.25 milligram IM every 15 minutes after ruling out the contraindication of this medication. And I will give misoprostol 800 microgram sublingually, followed by tranexamic acid 1 gram IV. And if still after these measures the patient still bleeds, then I will shift the patient to the operation theater, and I will examine under the anesthesia, and I will see that if uterus contracted or not. If the uterus is not contracted, then I will pass the balloon tamponade, and if still patient is still bleeding, then I will proceed towards the interventional radiology, and bilateral internal iliac ligation, and if it's still patient bleed, then I will take the consent for the hysterectomy, and call my consultant, and proceed towards the hysterectomy. And then after that, I will shift the patient to the high dependency unit or in ICU.
Okay. Okay, Dr. Tabinda, thank you. These are the 5 questions for you. Do you want to add any of the points in any of the questions of the above?
Ma'am, I forgot the definition of PPH. I don't know.
No, no problem. No problem. Okay, thank you so much. So now moving towards the Dr. Rekha. Are you there, Dr. Rekha?
Yes, I'm here.
Okay, okay. Your next question for you. You have read the scenario, right?
Can you show me again, please?
Yes, yes, sure.
Okay, fine, ma'am.
Okay.
Can you show me the person, please?
Okay, this is for you. Number 6.
As this is a major PPH, so I will follow the steps of the major obstetric hemorrhage protocol. After the initial resuscitation steps, after communication, resuscitation, investigations, then the monitoring and treatment of the cost will be done simultaneously. And I'm going to communicate as the resuscitation steps are already done. So as the uterus is soft, so I will start with the medical management. I will make sure that the patient is flat and we will keep the patient warm. I will ensure that I will check that the patient is not allergic to any medication because I have to give the medication. I will rule out the contraindications with certain medications. I will check their records with her permission. So I will start with I will rub up the uterus and I will ensure that the bladder is empty. We will ensure the patient is catheterized if required, and strict input-output charting will be done. Patient's observations will be monitored on the MEOS charting. My midwife will do all this. By checking her blood pressure, pulse, temperature, respiratory rate, and oxygen saturation. We'll start with the if the oxytocin bolus dose is not already given, we will give the IV Syntocinon 10 units internationally slowly, because this can cause the hypotension. And then the ergometrine 500 micrograms will be given after ruling out the contraindications like the hypertension and the cardiac disease. After the Syntocinon infusion will be started 40 international units in the 500 ml at the 125 ml per hour. But we ensure if the patient is pre-eclampsia, if any cardiac disease is there, then the fluid restriction will be done according to that. And then after that, the carboprost, which is then carboprost, it's a prostaglandin F2 alpha, will start this, but it can cause some bronchospasm, diarrhea, flushing. So we will not give the patients who is asthmatic. And IV transamine 1 gram can be given. It repeated 2 to 3 times in the 24 hours if required. And after that, the misoprostol will be given 800 micrograms sublingually. And but we after if still the patient is bleeding, then I will take the further steps from onward.
Okay. So if all the medical methods have failed to stop the bleeding, what will be your next step?
Okay, so I will communicate with my patient and his relatives that we are facing this complication. We are unable to treat this by medically, so it will be done by examination under the anesthesia. We will take the consent from the patient. I'm going to inform my consultant before that, and I will ensure that the patient is not having any coagulopathy problem. We will ensure the reps are available and the blood products are available. I will ensure the patient is not a Jehovah Witness. He accepts the blood if required. And also, I will inform the anesthetic theater and the staff to arrange the instruments for all that. And the patient will be examined under the anesthesia. WHO safety checklist will be given, followed. And also the antibiotic will be given to the patient because we are going to do the uterine manipulations to reduce the risk of the infection. So then and under the examination, we will check that the either still the uterus is soft and it's not contracted, and we check for the episiotomy, vagina, cervix for any tears, any retained products of the conception are there. So we rule out other causes apart from the H1E if there is any bleeding problems. If and then afterwards we take the next step of the balloon tamponade, and in baleen sutures will be applied. And also then stepwise devascularization will be done, one uterine, both uterine, and one ovarian, both ovarian arteries will be. And if the facilities are available, we will go ahead with the internal artery ligation and uterine artery embolization if the interventional radiologist facilities are available. And if not, then the subtotal hysterectomy will be done after the discussion between the two consultants. Yes.
Okay. So what will be a post-operative management of this patient?
I will shift the patient to the post-operative ward, either in the HDU or the ICU, depending upon the condition of the patient. We will ensure her observation will be monitored strictly on the Meo's chart. Strict input-output charting will be done. BT risk assessment will be done. And we will check that either the patient is not bleeding. We will ensure the blood tests are available. If there is any need of the blood transfusion, it will be done after the discussion with the consultant, hemodynamic condition of the patient, and the hematologist. And also we will ensure that her documentation will be done, and we will debrief the patient and her relatives that there is a major obstetric hemorrhage complication has happened. We will counsel the patient, and also we debrief the staff also. And if the blood group is negative and we have not removed the uterus, we will give the NTD also. And also we will if the uterus is removed, we will counsel the patient regarding the future fertility in terms of the surrogacy and the adoption. And if the blood loss is more than 1500, or if the uterus is removed, then the DATEX form will be filled. And also we will root cause analysis. I will do the risk management, also root cause analysis, documentation, debrief, and discussion will be done. If it is going so many cases are done, then the audits will be done also. We will debrief the staff also, reflective case practice and root cause analysis will be done. And I will counsel the patient further. Once the patient is hemodynamically stable, we will discharge the patient with the follow-up, contact details, patient information leaflet, and also write back to the GP about whatever has done in the hospital.
Okay.
And warning signs, symptoms will be given to the patient.
Okay. Okay. So your next question is, so what are the clinical governance issues in this patient?
Yes, clinical governance issues. There will be the duty of condor. DATEX form will be filled if the blood loss is more than 1500, if the uterus is removed. And documentation, debrief the patient and its relative, root cause analysis, discussion with the staff also, and reflective case practice. And I will enter the case into the portfolio. And yes, this is all I will do.
Okay, okay, okay. Thank you, Dr. Rekha. Do you want to add any of the points in your questions?
No, I think I mentioned whatever I have in my mind.
Okay, okay, well done. Okay, thank you. So coming to the first, Dr. Tabinda. Yes, you have covered most of the points in this, your 5 questions. But one thing that I want to tell you that you are going ahead to the next question, right? Like if the definition is asked, just stick to the definition. Don't go to the types and causes. Okay, let the examiner speak and ask the second question. Because if you will not give time, this is the only time limit of 10 minutes, right? So if you will not give the examiner time to speak or ask you next question, then it will be very dangerous. Are you getting me, Dr. Tabinda? Are you here with me?
Yes, ma'am. Yes, ma'am.
Yes. So stop till the question, whatever the question is, like if it's the definition, to stop after telling all the definition and whatever points you want to add in that, and then let the examiner speak to the next question. Okay? Because all the questions will not be
Okay.
shown up to you at the same time. You don't know what will be the next
Yeah,
question,
yeah.
right?
Yes,
Otherwise,
ma'am.
your approach was very good. You started off very well, except for the few clinical knowledge points that I will discuss about the definition and all that. So you'll come to know about this. Okay. And coming to the Dr. Rekha, yes, your performance was very good. Well done. You have covered. I don't think you mentioned you missed any of the point. So it was very good. Your knowledge and everything was perfect. So you even stopped in between the questions to let the examiner speak. So that was good. So coming to the examiner's key now. One by one, we will see about the questions that are asked. So first of all, definition of the postpartum hemorrhage. So the definition is it is the most common major obstetrical hemorrhage, and we divide it into the primary and secondary postpartum hemorrhage. So if the loss of blood loss of 500 ml or more from the genital tract within 24 hours of the birth of the baby, we label it as primary postpartum hemorrhage. And the secondary postpartum hemorrhage is when there is a bleeding from the birth canal from 24 hours till the 12 weeks postnatally. So we label it secondary postpartum hemorrhage. So now we divide the primary postpartum hemorrhage into the minor and the major. Minor is when the blood loss is between 500 to 1000 mLs. And the major further divided into the moderate and the severe. The moderate one is when there's the loss of 1 liter to 2 liters. And the severe is if more than 2 liters. Okay. So now, what are the causes? As we all know that the causes are in the 4 T's, the tone, tissue, trauma, and thrombin. So we need to speak like this, that these are the major causes of postpartum hemorrhage, and the most common causes, we know that the tone is the most common cause of postpartum hemorrhage. And this can be due to over distension of the uterus, or it can be because of any infection, intra-amniotic infection like chorioamnitis. It can be because of any functional or the amniotic distortion of the uterus. It can be uterine relaxants that can be used, or it can be bladder distension that can lead to the uterine atony. The other thing is that if there is any retained product of conception that are left behind, so that can cause postpartum hemorrhage. It can be if it can be because of trauma, like it can be laceration of the vagina, cervix, or perineum. So any laceration in the genital tract, or it can be uterine rupture. And if we are doing the vaginal birth after cesarean, so it can be due to the scar rupture as well, or uterine inversion is one of the cause as well. Now coming to the other cause is thrombin. So thrombin, like any coagulopathy, it can be hemophilia A, ITP, or it can be von Willebrand disease, or the previous postpartum hemorrhage can lead to the recurrence of the postpartum hemorrhage as well, DIC or therapeutic anticoagulation. So we need to dig out the history in detail to the patient to see what can be the cause in this. Okay. Now, this is the chart that is taken from the BJ or the journal, British Journal. So it can be primary postpartum hemorrhage. It is very good chart in which there's all the clinical findings, what investigations we will do, and how to manage one by one. Like if it's the poor uterine tone, then we need to go for the what clinical findings we will get in the patient, that the uterus will be relaxed, bulky, and soft, as it was in this patient. So we will go for the investigation, full blood count, coagulation profile, urea electrolytes, and also if the patient is not responsive, we might need to go for the ultrasound as well. And the management, we know from the our flow chart, the major obstetrical protocol. So we will discuss it later about the management. So it can be the tone, tears, or trauma. So retained tissue and coagulopathy. So whatever the cause is, we will treat according to the cause, the postpartum hemorrhage. If it comes as secondary postpartum hemorrhage, so the causes can be endometriitis, any infection of the endometrium, or pseudoaneurysms or uterine artery aneurysms, or the retained tissue as well. So this can lead to the secondary postpartum hemorrhage, and then accordingly we will deal according to the cause. We will deal with this secondary postpartum hemorrhage. Like we go for the oral antibiotics, or if it's any aneurysm, we can go for the surgical management of uterine artery embolization as well. Or if it's the tissues, then obviously we need to evacuate that. So the one question was how to manage the minor PPH. So yes, you were right, Dr. Tabinda. You just started off with the IV access. A 114 gauge cannula will be inserted. Urgent venipuncture, 20 ml of blood will be required for group and screen. We need to go for the full blood count, coagulation screen, including the fibrinogen. We need to monitor her vitals, pulse, respiratory rate, blood pressure recordings every 15 minutes, and a warm crystalloid infusion will be done as till the blood arrives, or till the day we require the blood transfusion, so we can give for the crystalloid infusion. So this is the management of minor PPH. Now coming to the major PPH, so we need to follow the major obstetrical protocol, starting from the airway, breathing, and circulation. Then position the patient flat, keep the patient warm, as well as we need to transfuse the blood as soon as possible if clinically required. And until the blood is available, we need to infuse 3.5 liters of warm clear fluids, initially 2 liters of warm crystalloids, okay, and then the colloids accordingly. So this is the major obstetrical protocol. We need to speak up like as it is, the protocol is to the examiner that initially we need to communicate, resuscitate at the same time, and we need to call for help. The multidisciplinary team will be called, and then resuscitation will be done. We need to send the blood for investigation, start off with the full blood count, coagulation, urea electrolytes, liver function test, ECG and oximeter to be attached, as well as we need to pass the Foley's catheter. Also the blood products to be sent. Until the blood arrives, we'll start off with the crystalloids and the colloids. Then we'll speak about the medical management, and once we tell about the medical management, need to say that we need to rule out the allergies before starting off any medication to the patient. Okay, and then one by one, as we know that the ergometrine is contraindicated in hypertensive and the cardiac patients. So tell that the ergometrine will be given after ruling out that the patient is not hypertensive or any cardiac problem. Similarly, carboprost, as the Dr. Rekha mentioned that about the ruling out the asthma because it leads to bronchospasm. So this is all about the medical management that we need to speak one by one. So after that medical management, the next question was that if the medical management fails, so what will we do next? So we'll take the patient to the theater after taking the consent, maintaining the WHO safety checklist. So all we need to speak, and then we need to see what is the cause of the PPH. If it's stone, tissue, trauma, then according to the cause, we will treat the patient. If we see that whether the uterus is contracted or not, and examine the anesthesia. If any clotting abnormality is there, we need to correct that. Okay, then the first surgical management is intrauterine balloon tamponade by the Bakri balloon or the Rush balloon. Brace sutures will be applied if the initial management fails. Then if the conventional radiology facilities are available, so we will go for that. Then the surgical options are the stepwise uterine devascularization, bilateral internal ileal ligation, and hysterectomy will be done after the consultation with the second opinion from the second consultant. And then the uterine artery embolization is the last resort. And then after the post-operative management will include that they will shift the patient to the high dependency unit or ICU, depending on her condition, perform the duty of candor, debrief the staff, patient, and the relatives about the condition, maintain the Meos chart every 15 minutes, recording the blood pressure, respiratory rate, and the pulse. Input-output charting will be recorded. Analgesia will be given to the patient. Antibiotics after ruling out the allergies. We need to follow the enhanced recovery program, as well as incidence reporting will be done if the blood loss is greater than 1.5 liters or the patient end up with a hysterectomy. And also the venous thromboembolism prophylaxis will be given, CBC, and we'll send the complete blood count as well as transfuse accordingly, according to the patient's condition. Then counsel about the future implication about the fertility, pregnancy, and delivery. Also, we write her back to her GP or the midwife and give her the patient information leaflet. So this is all about the post-operative care. Now the clinical governance issues. So all the documentation is very important that we need to document all the necessary essentials like staff attendance, time they have arrived, sequence of events in the chronological order, timing and sequence of administration of pharmacological therapy that we have given, time of surgical intervention if done, also condition of the patient throughout the various steps, timing and the amount of fluid that is given or if the blood is given. So all needs to be documented very clearly. Then the debriefing of the staff as well as the patient and the birthing attendant is important. Datex incidents reporting form will be filled, duty of candor to be done, as well as we'll alert the risk management team. Drills will be done, simulation training, as well as the discussion about the audit and the reflective practice. So this is all about the clinical governance issues that we discuss. Anything that you want to ask in this, Dr. Tabinda, Dr. Rekha, or any of the candidates from the participants?
I was thinking that this is as vaginal delivery, so we should not go for the brace suture.
Yes, we'll say.
We should go for the.
Yes.
I was thinking this.
Yes,
That's why I
you are
skipped
right.
the brace suture.
Yes, you are right. But yes, if just say that if there's if it's after the cesarean section, then we can go for the B-Lynch brace sutures. Like you can just say like this. Okay. Hello. Hello. Can you hear me?
Ma'am, hello, ma'am.
Yes. Who is this?
Yeah, but if with the medical management, the bleeding is not. Yeah, can you hear me?
Yes, I can hear you.
Yes, Fatma, we can hear you.
Yeah, ma'am. But I'm saying that if we are taking patient for examination under anesthesia, and we have to open the patient with the medical management, the first step will be after Bakri balloon will be the brace sutures, even if it is a normal delivery.
Yes, normal delivery
How
is
this
not a
sounds?
contraindication for brace suture. Brace suture is one of the conservative surgical management. So you should.
Yeah, exactly.
Ma'am, I want to ask that if
Yes,
the
ma'am.
patient go in PPL during cesarean section, then the first step would be the brace suture.
Zubia, we
Hello?
cannot hear you.
Ma'am, she is saying if the patient is going PPH after cesarean section. Dr. Zubia, you are saying that the abdomen is open and like we just